I hope everything is good down there in Austin. Okay. This is my disclosure statement. Okay, now just a couple overall comments. Two great American philosophers. No medical presentation is complete without a quote from Sir William Osler and a quote from Yogi Berra. So,
can you exit that little window on the lower right-hand corner? Just that little.
Whoops.
Not the end call, the X.
Exit. Yes, got it.
There you go.
Okay. All right. So Dr. Osler said there's no more difficult art to acquire than the art of observation. If you listen long enough, the patient will give you the diagnosis. Yogi Berra said something similar. You can observe a lot by watching. And I would have never seen it if I didn't believe it. So we need to do individualized assessment, and that's a critical thing. And that was really a part of medicine for a very long time. So it's not just Osler emphasizing it, it's Hippocrates. You also have evidence-based medicine, which I think has been misunderstood. It's really the balance between clinical judgment, best evidence available, and patient preferences. Now, we've also found a shift towards third parties making decisions, and there's been this tug of war between who has the power in medical decision making. Is it the patient, the treating physician, or is it a third party? You know, when I was in medical school in the late 60s, one of the physiology professors said, you know, we're starting to see computers in medicine, and someday you'll see this evolve where you will have doctor on one end of the computer and then a doctor on the other end of the computer. And the doctor on one end of the computer does evaluations and feeds information into the computer, and then the computer tells him what to do. And the doctor on the other end of the computer programs in algorithms of how decisions should be made. Now, in some ways, it has evolved that way. Except the only exception is that it's really not a doctor on the other end of the computer. It's really more a business person. So when we think of clinical assessment as an overview, we have to do an in-depth history and review a system. Now that's basically what we were taught to do in medical school. And we would spend 3-4 hours doing one evaluation. And it was very tedious, time consuming, but that was at the core of properly assessing a patient. So part of that is finding out what exactly are the complaints, and then listening carefully, following the advice of both Osler and Berra, and then giving it a lot of thought. Is this a multi-system illness? Are there multiple problems, cognitive, psychiatric, etc.? Is there comorbidity? And pattern recognition, that's a critical phase. What's the pattern that we see? And then what's a differential diagnosis? And then lab work and medical judgment. Now we have to be careful. Some people think of lab work as objective and physical assessment as subjective. And that's not the case, because a lot of lab work is based on subjective criteria. So sometimes the lab work may be more.
Still with us? Can you hear me? Can you hear us?
Yes.
Okay, great. Can you turn down the volume just a bit on your end so we don't get an echo? And
okay.
Also, can you turn on your video, please?
Whoops. Okay. Wait a minute.
Little video icon at the bottom there.
Okay, video.
To the left. There you go. Keep going. Just a little bit more of the little video. Nope, nope. To the right. To the right. To the right. There it is. Not the microphone. No, no, the video. Right. The video. No, not the plus sign. The little camera.
Yeah. I don't see it on my screen. Let me
scroll up just a little bit and it'll come back.
Oops. Yeah. let me,
There you go.
there we go.
Video. And then, like I said, please also just turn your volume down a little bit on your side so there's no echo. It's kind of cutting out a little bit. Your ability to hear me, turn that down a little bit.
Okay. All right, good. Is that all right?
Yes, and now, great.
Okay.
Now minimize the Skype window. Thank you.
Okay. All right.
There you go. Perfect. Okay. Perfect.
Okay, so when we look at doing an assessment, what do we give greater weight to? We have a complete history. We were looking at environmental exposure, review of systems, the psychiatric assessment, thorough exam. What's the time course of how have things developed over time? Comorbid conditions, a differential diagnosis, pattern recognition, the best evidence available, lab, clinical judgment, disease progression after treatment, and response to any antibiotic, antimicrobial treatment, and therapeuticus ex juvidicus. Now, that's a Roman phrase that basically means you give something your best diagnosis, and if acting on that diagnosis is effective, then it confirms that you were probably correct. However, if you give that diagnosis, give that treatment, and it's not giving the response you had anticipated, then you have to rethink the diagnosis. And then guidelines, which are the guidelines we're referring to actually valid or not? That's something we have to think about. So is there an adequate assessment? That's a big issue. And a lot of times with Morgellons patients, there may be an inadequate history or an inadequate assessment. And a lot of times someone does a very cursory exam, maybe ask a couple of questions, and then they say, well, it must be this. And it's often very difficult for a patient to be reassured that that was sufficient to answer their questions. So is that, when a patient questions that, is that delusion, or is that a valid questioning of the lack of thoroughness of the assessment? Now, there's a lot on this slide, but this is really the core of what I'll be covering, but I'll go into a lot more detail in each section. So this is how I've been doing assessments for the past 20 years. And I basically do this, and it ends up being 280 items that I do. It takes about an hour and a half to do. And it's a complex review of systems that's basically relevant to multisystemic illness that we see with infectious diseases. So I break it down into each category. For example, the psychiatric part, which think of is a logical way to break this down. The cognitive section is looking at the cerebral cortex, what's going on in the cerebral cortex. Then the psychiatric, you're looking at the limbic system, the second lower level of the brain. And then you're looking at vegetative symptoms, which is the brain stem. So the brain stem, limbic system, cortex are your three basic areas of the brain. Then we're looking at other neurological things, cranial nerves, peripheral nerves, spinal cord, nerve roots, autonomic nervous system, other parts of the nervous system, and then going on to the musculoskeletal system, the genital urinary system, cardiac, gastrointestinal, and then immune symptoms. So this is really what we really have been taught to do, and it's important not to deviate from our roots in classic traditional medicine. So now I'm not going to emphasize so much, and also the skin condition, which I don't have in here, but that's particularly relevant, and that's an area that I'm not going to cover that I think has been covered by other people. But I'm going to focus particularly on the cognitive, psychiatric, vegetative, neurological, and the autonomic nervous system part of the exam, knowing that those other parts also need to be done to be thorough. So when we look at the, so this is this breakdown of smaller outline from what I had before: cognitive, emotional, vegetative, behavioral, and then psychiatric syndromes, neurological, and somatic. First, with cognitive. Cognitive can often be broken down into like 5 basic categories. One is attention span issues, memory, processing, imagery, and executive functioning. So I'll expand on each one of these areas. And by the way, this workup that I do is on the internet, and it's on my website, and I'll show it at the end, mentalhealthandillness.com. Anybody can download it and use it. So with attention span, now a lot of times you see attention deficit disorder, but that's acquired since birth. It's always there. This is an acquired attention span that you see with these infectious conditions related to immune activity. So there's difficulty, an acquired difficulty with sustained attention, difficulty with allocation of attention. For example, if somebody's in the back of the room, they're chewing bubble gum, it might be distracting. Can you have selective attention and block that out and pay attention to the main business at hand, or is there difficulty filtering out attention selectively? Another good example is being in a restaurant at a table. Can you pay attention to the person you're with, or is there too much focus on the people around you? Then being easily distracted by frustration. There's an emotional piece here as well, where higher levels of emotion interfere with focus. And then hyperacuity and emotional reactivity to different sensory input, particularly sound, sometimes light, touch, smell, sometimes vibration. But this hyperacuity is quite interesting because you can see that when they do brain imaging capability, it goes straight to the emotional center. So if someone makes loud noises or some sensory input, it has an immediate negative emotional reaction. And then this can lead to sensory overload and flooding. So a person often then feels flooded, overwhelmed. It sounds like a bad joke, but one time we had a Lyme meeting in Times Square, and it was part of the American Psychiatric Association meeting there. And it just happened to be in New York City that year, but a lot of Lyme patients were attending, and they had great difficulty navigating through Times Square to get to the meeting. But that's the example of something that you don't want, because that ability to filter is impaired. And studies with the thalamus, which has a gating function, show that thalamus is overactive, and it is unable to filter out sensory input the way it would be in a state of health. So that's attention span. Now, the next thing is memory. Now, you cannot remember what you never paid attention to in the first place. So we can break down memory into different categories. Working memory is immediately holding something while you're solving a problem. Working spatial memory has a geographical capability. Do you remember where you parked the car in the parking lot? Do you remember how you got in the building? It's geographical, short-term, and then long-term memory. Long-term memory often remains intact before the infectious process. So there can be a gap there of, if a person was sick for 3 years, they may have remote memory for the 3 years preceding, but the memory during that era of illness may be fuzzy, impaired. And then encoding errors. Now, part of memory is retrieval and part is encoding. So it's, you need to pay attention, and then you need to encode memory, and you need to store memory, and then retrieve it when you need it. So there can be retrieval issues of difficulty retrieving numbers, words, names, faces, for example. And sometimes that ties in with what I'll talk about soon, which is the slow processing. And then sequential memory. You can see impairments there where there can be reversals, letter reversals, name reversals, spelling errors, sometimes what we call neologisms, where someone invents a word that is a nonsense word, but you can see where it makes sense, where someone's retrieving a problem. Now these kind of memory problems are quite different than the memory problems we see with Alzheimer's. This is a white matter encephalopathy as compared to Alzheimer's that's predominantly more of a gray matter encephalopathy. So with Alzheimer's, you actually lose memory, whereas with white matter problems, which is what we see with these immune-based problems, there is impairment with processing and errors and slowness in processing, but basic innate intelligence remains intact, and the memory can remain, but it's just difficulty accessing it when you need that. Okay, now processing, which can be broken down into different areas. One is reading comprehension or auditory comprehension. There's receptive and expressive processing problems. For example, if someone has slow processing, it's very similar to, if you've ever seen a Peanuts cartoon, which probably all of you have, when the adults are talking, it's wah, 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 wah. So it's like that, where a person's sitting there, they're hearing the words, but they're not digesting the content. That's a processing impairment or a slowness of processing. Now, sometimes it's just a slow processing. And for example, with reading, when it's reading, a person can read slower and then they can process the information. But it's particularly difficult with spoken language that's going at a certain pace where it's hard to keep pace with the speed at which the information is being imparted. Now, it's similar to an assembly line, where both an input and output of how fast are words and sentences turned into paragraphs and abstracted into meaning, and how fast and capable is a person of doing that on the opposite end. Now, sometimes we'd see with processing impairments, spatial awareness difficulties, left-right confusions, different spatial orientations, mathematical writing abilities, difficulty with fluency of speech, stuttering, slurred speech, decline of handwriting. I used to work in a mental health clinic in North Carolina early in my career, and I would be in these very small, tiny examining rooms, and the people there said, it's an unusual thing, but a lot of times you'll ask these people, you'll talk to them, and they'll look at you with a blank expression and say, who, me? And you're in a very small room, and there's nobody else you can be talking to. And I found that people were repeatedly doing that. And it was a puzzling thing to figure out, but it seems like it was a habit that a lot of these loggers had, where a lot of them were encephalopathic from some chronic infectious process, maybe Lyme, who knows what. And they had very slow processing, and they always use those expressions to buy time while they were trying to process what you were saying. Just like some people say, it's an effort to buy time to process the information. So imagery. Now, imagery is something that I don't think we pay enough attention to. And this is, there can be intrusive images. And I see this a lot with infections. And this correlates with brain inflammation, particularly brain inflammation affecting the temporal lobes. And these can be intrusive images, thoughts, emotions. They just come. They come out of the blue. They can seem like almost similar to what we see with post-traumatic stress disorder, or it may be almost like a preview to a cheap horror movie. And they come, randomly, and they don't make sense. Now, that's quite different than hallucinations. And when I have seen hallucinations with Morgellons or Lyme patients, a lot of times they're quite different than what I see with schizophrenia. It's more commonly musical hallucinations, but occasionally it's like talk, it's more like radio talk. Or when there are hallucinations, it's often an awareness of hallucinations. If you look at brain imaging to try to understand hallucinations, there's one part of the brain that is functional when someone has a hallucination, and that's that ability to tell what's coming from inside versus what's coming from outside. The best thing that you could compare it to is when you wake up in the morning and you're kind of half awake, half asleep, and you're dreaming, but you're sort of awake, and the two get muddled together. That's what hallucinations are, except it's when someone's awake. And then illusions or distortions. Now, executive functioning is a very significant area, and this is the capacity to initiate, sustain goal-directed behavior. So this is very critical in productivity. And this is different than what we may think of as attention deficit disorder, because executive functioning is productivity. So a lot of jobs, particularly higher functioning jobs, require executive functioning, and slight changes in executive functioning can cause very significant impairments. So in order to be effective here, we need attention. That's a basic ability, which I covered before. And this is really pulling together all the cognitive domains that I've already covered. And then being able to concentrate, organize, prioritize, plan, do multitasking. But brain fog is something that comes up a lot. And brain fog is, the best way to compare that to, thing to compare it to would be take 100 milligrams of Benadryl and then go about your daily activities. So there's a sluggishness that people have. And then other thought content related to executive functioning may be racing thoughts, intrusive thoughts, obsessive thoughts, or apathy where it's difficult taking initiative. What I also see is many patients have time management impairments who did not have time management problems before. They just lose a sense of time. That's basically a multitasking capability to be able to do something and keep the time schedule in mind. So I don't run over giving this talk, for example. So now we're getting into the emotional area. So that's the cortex, cerebral cortex. Now we're looking at the limbic part of the brain, the emotional part of the brain. And a lot of symptoms we sometimes see. Now, often you see in early infection, in early disease, more early brain fog, those problems. The emotional symptoms don't come until really later, usually a couple years or so. Or the irritability and some of this may start earlier, but it's a sequence that evolves over time. You can see low frustration tolerance that can evolve the irritability, which is the outward manifestation of low frustration tolerance, sudden abrupt mood swings, hypervigilance, paranoia, dysphoria, anxiety, apathy, anhedonia, which is a lack of pleasure in life, where it's hard to feel good from good, depersonalization and derealization. So depersonalization is a feeling of attachment, that one isn't there. The opposite is presence. Derealization is your surrounding doesn't seem real. Some people tie that in with brain fog, but it's actually a little bit different. And again, with paranoia, it's not, there's a part of the brain that's healthy suspicion. So if someone wants to sell you the Brooklyn Bridge for a bargain price, you should be suspicious, but it should be a normal level of suspicion. And I think when true paranoia exists, there's excessive suspicion. Somehow that suspicion part of the brain is overactive. And then when someone has excessive suspicion, they come up with all kinds of theories to try to explain it. Now, rarely do you see isolated paranoia on only one issue. And that's, I think, a significant point where how could someone have a delusion of parasitosis or paranoia, and that paranoia and delusion go hand in hand, if they don't have delusions or have paranoia that affects other areas of their life? It's very, very rare to see isolated paranoia or isolated delusion. Okay, now then behavioral issues. We can see disinhibition, poor impulse control, exaggerated startle. That goes also with the sensory overload, the hyperacusis, sensitivity to sound, explosive anger, sometimes suicidal, homicidal. Whenever I've seen people that were homicidal with these infections, they were also suicidal. I've never really seen it where they were homicidal without being suicidal. At the same, along with it, being accident prone, being less active with their personal life and their work life, often a lot of marital discord, sometimes substance abuse that complicate problems. Now, this is a big issue with Morgellons, is to particularly look at substance abuse in regard to stimulants, because a lot of stimulants, opioids, the withdrawal of these meds can give sensory findings that can actually cause I hate to say the word, but it can cause a delusional parasitosis that actually is a part of withdrawal, so withdrawal syndrome, and that needs to be considered separately as part of the differential diagnosis. And then often people double check to make up memory impairments. They have crying spells. Sometimes the crying spells are without actually being depressed. It's what we call labile affect, where they can come from nowhere. And then we're looking at the common psychiatric syndromes. Like depression is very common. That correlates with being in a more inflammatory state. When you see mood swings, it's a little different than a normal bipolar. It's very rapid shifting. Panic attacks that may last more than a half hour, that's a big giveaway. Or obsessive compulsiveness, social anxiety. Social anxiety is an exaggerated feeling of social sensitivity, of being scrutinized, that I'm being scrutinized more than I really am. Even though logically a person knows that there's just the feeling that all the eyes are on me, and generalized anxiety, and sometimes you see a post-traumatic stress-like syndrome. Sometimes you see true post-traumatic stress because of the trauma of dealing with the healthcare system or the trauma of these impairments are creating in a person's life. And basically, almost any psychiatric syndrome can go with these affections. So, and a lot of people will describe, I never had anxiety, I never had social anxiety, I never had panic before I had this happen to me. So it came with it. You have to look at the time of when it began. And as I said, the psychiatric part, this is usually a couple years down the road. It doesn't begin right away. It's usually later in the course of the illness. And now, okay, so we've covered the cortex and the limbic system. Now we're working our way down to the brain stem. So we think of that as your basic vegetative functioning, sleep, eating, sexual functioning, temperature control. And I can break these areas down a little bit further. So sleep is critical. That's something I make a big thing about. And having non-restorative sleep, that's a key thing. There was a news flash that just came out about a day or two ago that trazodone can prevent dementia, but that occurs really because it helps with deep sleep. It helps with restorative sleep. And non-restorative sleep pushes someone towards dementia as well as many other things. So when we look at that, is there trouble? Is sleep restorative or not? The first thing to look at, the first question to ask. And then the next question is, do you have trouble falling asleep? A lot of people will say, yeah, I just can't fall asleep. You have to look at that in more detail. Is it trouble turning off their head, their thoughts, their emotions, their body? And then you look at, do they wake up in the middle of the night as a result of maybe some physiological condition, get up to go to the bathroom, reflux, or other sleep apnea, problems like that? Or is it early morning awakening? And early morning awakening particularly goes with depression, where they wake up at 5. Then is there hypersomnia during the day? So is there a flattening of circadian rhythm? Ideally, you're well rested at night, and then you jump out of bed ready to attack the world, and then you go in a deep restorative sleep. But people with chronic illness, they're not asleep when they're asleep, and they're not really awake when they're awake. There's a flattening of circadian rhythm, or a shift, often a shift towards later in the night, so they become night owls. And that often ties in with that sensory overload, where they feel overloaded with sensory input, so they like being alone at night. They can hear themselves think. And then fatigue correlates with sleep disorder. Non-restorative sleep goes hand in hand with what we call the terrible triad of cognitive impairment, fatigue. Then eating disorders, a lot of times I see weight loss early and then sometimes weight gain later, depending on the course of the illness. So you can also see emotional overeating. Ideally, your stomach tells you when to start and tells you when to stop, and you don't really have to think about it. But people with eating disorders either don't have normal appetite, they may gain weight because of emotional eating, carbohydrate craving. So that's important, to take a history. Are they eating from their head or eating from their stomach? Then sexual functioning, often you see a decrease of libido, rarely increase, but sometimes, and menstrual irregularity and decreased capacity for pleasure. That goes with anhedonia, that what I spoke about before, the lack of pleasure of life. Hedon was a Greek god of pleasure, and without means without pleasure. So that's the opposite of what we think of hedonism, which is pleasure seeking, is anhedonia. Excuse me, but a lot of people who are really hedonistic are actually anhedonic because it's hard for them to feel pleasure, so they often do things to extreme. Now think of Bellucci in Animal House. That's a good example of hedonism, but actually it's truly anhedonia, because why does it take so much to feel good? And in temperature control, we can often see low body temperature, we can see low-grade fevers, night sweats, chills, and often a worsening of the skin symptoms occurring at night for some reason, and that's good to look at in history. Then looking at neurological. Now, just as we broke down the brain, we also have to break down with mental function. We break down the neurological into different parts. So we think of headaches, cranial nerves, seizure activity, sensory system, motor system, reflexes, spinal cord, and autonomic nervous system. So with headaches, we often see headaches that radiate from the neck up to the scalp, the eyebrow. Those are cervical radiculopathy, and they can go more with nerve entrapment, irritation coming out of the spinal cord in the cervical area, migraines. Sometimes we also see migraines triggered by sexual, like orgasm or sexual activity. That I pick up sometimes. TMJ, tightness in the temples, tension headache, which is a dull, nagging headache, cluster headaches that come in cycles, sinus headache, a pressure like in the forehead, thunderclap, a jabbing headache. So I often try to break these down. Often headaches are complex, and you can see where it may start with one type of headache and then progress onto other type of headaches. So it's good to look at how do they actually begin. And then breaking down the cranial nerves. Now, a big thing, particularly with Jones patients, is they often have the sensation of things racing across the field of vision, similar to perception of tiny flying insects. And that's, it's hard to understand that, but it's a visual, like, perception. It's not exactly a floater, but it's, or flashes, but it's a visual perception that occurs. So it seems like it's some type of visual processing impairment that a lot of patients very consistently describe. Then you see dry eyes, eye pain, shadows on the side of the field of vision, and then some other findings less commonly, for instance, panopsia, where there's a perception that things are moving back and forth, almost like you're looking across the hot parking lot on a summer day, and there's a mirage effect in the field of vision. Then smell, the other cranial nerves always do go through each cranial nerve, and invariably you often see some cranial nerve problems. For example, Tullio's phenomena, which is very specific for spirochetal disease, where there's loud noises cause nausea, and it's and motion sickness. So it's a quite specific thing. And then loss of speech, choking. So you go methodically through each of the cranial nerves and see, and invariably you see some cranial nerve findings in most patients. And then looking at seizures, invariably I see more complex partial seizures, and a lot of, this is a debate that's going on for decades, and a lot of people do EEGs and they often don't find anything, but I think it's a deep limbic seizure, because invariably these partial seizures, you see a response to anticonvulsant medication. It's very consistent, and so I think they are deeper seizures, even though they're sometimes pick up on EEGs and sometimes not. I go more by the clinical presentation than the EEG. Then the neuropathy, which is particularly significant, and I think we see a lot of peripheral neuropathy with this burning, it's called formication, which is the clawing, stabbing sensation. It's a peripheral neuropathy symptom. And when people do small fiber neuropathy biopsies, they can see inflammation in the fibers that explain it. So you could get neuropathy as a result of, let's say, spinal cord problems on rare occasions, but more commonly nerve root, or it could, which is radiculopathy, or it could be small fiber neuropathy, or it could be some combination of those. So that's the sensory part. And then you can also, and also odd sensation that my skin doesn't feel right. There's a misperception of wetness or sometimes water, of a greasiness, a feeling of greasiness, and it's a sensory impairment, a type of neuropathy, I think, so that the actual feeling in a person's skin or hands, there's a difference there. And then we get weakness, tremor, muscles, and then postural orthostatic problems. And then I always do a Romberg with people, and that often is where they stand up, close their eyes, and that's a good way to see if they have a neuropathy problem. So it tends to be worse at night with sensory loss, skin sensations, itching, skin feeling greasy, crawling, burning, stabbing, and it's a feeling of insect crawling on the skin. It feels like that, although, you know, the odd thing is it feels like there's an insect, but it is an infectious disease, so it's not such an unusual conclusion to think that I've got some parasite. So that's what we call formication, which is this feeling of crawling, but that's also seen with other conditions. It's seen with different dental problems. It's seen with diabetic neuropathy. It's seen with other neuropathy kind of conditions. It's also seen in withdrawal states. And a lot of these people aren't called delusional just because they have that symptom. So then here's the other symptoms that I'm not going to go into: the musculoskeletal, cardiac, pulmonary, GI, genitourinary. Genitourinary actually comes up quite a bit. But invariably you find things when you do that thorough workup. And I'm going to go through these because other people have really done this, and I want to see if there's any questions. So basically, complex diseases require complex assessment and complex explanations. So we start by defining it and listening carefully. So to properly understand mind-body connection, knowledge of general medicine, psychiatry, and how the body and the brain are connected is necessary. And there is a clear link between Morgellons and some infectious toxic exposure causing a multisystemic illness, neurological impairments, and psychiatric conditions. And the diagnosis of delusional parasitosis should be given with great caution, and only when it truly meets that definition, and it should not be given as a way to avoid doing a thorough workup. So, common differential and conclusion. Let's see. So here's what we don't want to do. This is a cartoon I made a number of years ago. This is called misdiagnosis, okay? So that if a minimal treatment doesn't work, it's all in your head. But apparently a lot of people run into this. So, and then here's the website, Mental Health and Illness, where you can have that assessment and download it. And Dr. Saverly's, I often do her assessment as well. I don't know if she's there now, but I do that, and I also do this assessment, and that's how I do my workup for my Morgellons patients. Are there any comments or questions at this point?
Yeah, we'll take just one or two questions here.
Yeah, I think, yeah.
The question is, does it concern you that some of your dermatologist peers are diagnosing delusions of parasites?
Well, here's what I run into, and this is something we all have general medical background, and some of us keep current better than others. And I read a deposition of a doctor, and they said to the doctor during the deposition, "What's your background in psychiatry? What's your training?" And this doctor said, "Well, 40 years ago, I did a 1-month rotation in a state hospital." And that was the extent of his psychiatric background. So to make any diagnosis, you need some training, capability, competency, and to know how to do a thorough assessment. So it's within reason, if a dermatologist is knowledgeable about psychiatry, that maybe he could, but just like I as a psychiatrist could give a dermatological diagnosis, but I know that's outside my area of expertise. And humility is a good trait in medicine where we have to know our limitations. So when in doubt, it's good. I think a lot of doctors make a diagnosis by exclusion. I can't explain it, so it's psychiatric. Rather than saying, well, does it truly fit with the psychiatric syndrome that I'm calling it? That's a critical distinction that's needed to be done. And I think a lot of doctors make the psychiatric diagnosis too quickly without an adequate assessment.
Thank you, Dr. Bransfield, and I think we're out of time on this one.
Okay,
but,
thanks.
But thank you very much for your time today. A round of applause, everyone.